The topic for this presentation is upper airway obstruction. Most of the medications that we administer, that is bronchodilators, are given to treat peripheral airway obstruction. However, upper airways are also subject to obstruction from different causes. Unfortunately, upper airway obstruction is often mistaken for peripheral airway obstruction, and inappropriate therapy is given. Therefore, it is very important for respiratory therapists to recognize upper airway obstruction and recommend appropriate therapy for its treatment. Now, please understand that you must listen to all of the audio and visit all of the required web links to receive credit for this lesson. Time has been allocated within the lesson for you to do so. The non-required links are marked as FYI. Here is the learning objective for this presentation. When you finish here, you will be able to describe the etiologies, pathophysiology, manifestations, diagnostic procedures, and management of upper airway obstructive conditions. This first section will deal with the etiologies of upper airway obstruction, which, as you will see, are quite numerous. First, we'll see what airways we are talking about. The upper airways are those between the mouth and the carina. The upper airways can be intrathoracic, which are from the carina to the vocal cords, and extrathoracic, those airways that are superior to the vocal cords. We also categorize the upper airways in this manner. There are supraglottic airways, which are above the true vocal cords, intraglottic, which involve the vocal cords, and infraglottic, which are below the true cords but above the carina. Foreign body aspiration is a common cause of upper airway obstruction. The most common victims are children because they will put anything in their mouth, and once it's in their mouth, aspiration is a possibility. I've cared for a few kids who died of aspiration. One of these was lying on her back as she enjoyed a jawbreaker and aspirated it. She eventually died. Intoxicated patients are another group who are likely to aspirate, especially if they are in the supine position. If they are supine, the risk for aspiration increases. Common aspirates include vomit, but for some types of patients, their own teeth may also be aspirated because many of these have very poor dental hygiene. Another group of patients who are likely to aspirate includes stroke patients because of their impaired swallowing ability. Upper airway obstruction can result from the edema that is caused by infections. These infections include viral infections such as croup or laryngotracheal bronchitis, epiglottitis, which is a bacterial infection, tonsillitis, and finally diphtheria. Although diphtheria is very rare in the United States because of widespread immunization, it still occurs because there are people in the U.S. who have never been immunized against diphtheria. Another source of upper airway edema is called angioedema. This is a rapid swelling of mucosa, submucosa, and even the skin. Commonly, this is associated with anaphylaxis. Agents that are likely to be associated with angioedema include radiocontrast agents, opiates like morphine, aspirin, and non-steroidal anti-inflammatory drugs. Angiotensin-converting enzyme, or ACE inhibitors, are used to treat hypertension. These include Zestrel, Vasotec, and Capitan. ACE inhibitors have two adverse effects associated with them that are important to respiratory therapists. The first of these is a chronic cough. The other is angioedema. In the past couple of years, I had 2 patients who reacted to vasotec with angioedema and required intubation. One of these patients developed edema of the tongue that was so extensive that we could not close his mouth because his tongue was sticking out. Another source of upper airway edema with which respiratory therapists are quite familiar is post-extubation tracheitis, and we'll talk about that later. Also, there is edema that is due to anaphylaxis, and this will be angioedema, which is frequently associated with medications like penicillin, with insect stings such as bees and wasps, food allergies, especially peanuts and seafood, and animal dander, especially felines or cats. Airway edema also occurs as a result of inhalation injury. Common causes include burns, where thermal injury can cause complete airway closure in a very short time. Associated also with burns is injury due to inhalation of smoke, which contains numerous irritants. When buildings burn these days, a lot of plastic burns with them, releasing fumes that were unknown in our grandfather's days. There are other noxious inhalants, for instance, chlorine gas. Inhalation of chlorine is mostly seasonal because of people using chlorine to treat their swimming pools. Upper airway obstruction can be anatomic, resulting from congenital or inborn airway anomalies. Some of these anomalies include micrognathia, which is a small mandible, macroglossia, which is a large tongue and commonly associated with Down syndrome or trisomy 21, laryngeal webs, vestibular rings, and also vocal cord dysfunction, which may be acquired, and we'll talk about that later. If you click on the link below, it will take you to a video for an explanation of laryngeal webs. Acquired conditions that can result in upper airway obstruction include trauma, such as laryngeal fractures, neoplasms, that is, tumors of the upper airways, hematomas, as may result from accidents pertaining to line insertions like central lines and PA catheters, and central nervous system depression, which causes relaxation of the muscles that control the upper airways. As we are very much aware as respiratory therapists, acquired causes of upper airway obstruction include tracheal stenosis as a result of tube cuff damage. Also, vocal cord paralysis has resulted from endotracheal tubes and intubation. If you click on the links below, you can go see images and videos of tracheal stenosis. Laryngospasm is a source of airway obstruction. This is uncontrolled, involuntary muscular contractions of the laryngeal cords. Usually this lasts less than 1 minute, however, the duration can be longer. This is a complication of intubation, extubation, also gastroesophageal reflux. If you click on the first link below, you can see a video of laryngospasm. Click on the second one. It is a humorous video by a singing group known as the Laryngospasm. This is medical humor. Vocal cord dysfunction is paradoxical vocal cord adduction during inspiration that results in partial airway obstruction. It is often mistaken for asthma with inappropriate therapy administered. This is a very important condition for respiratory therapists. A few years ago, I was called to the ER to treat a patient for wheezing. Of course, albuterol by nebulizer was the treatment that was ordered. As I treated and visited with the patient, he told me that he was new in this part of the country and asked me if I knew of anyone who could manage vocal cord dysfunction. This raised a red flag for me because I had attended a continuing education lecture in San Antonio where a pulmonologist presented vocal cord dysfunction. She had emphasized that vocal cord dysfunction is commonly treated as asthma with inappropriate medications. Of course, I informed the patient of a pulmonologist who I knew at Temple University in Philadelphia. Then I approached the ER doc and asked him if he knew about the vocal cord dysfunction. He told me that he had never heard of it. End of story. As I mentioned before, vocal cord dysfunction, or VCD, can be congenital and or acquired. The list of possible causes include congenital idiopathic VCD, injury to the cerebral cortex, compression of the brain stem, psychopathology, malingering. Therefore, VCD also can have a voluntary element as well as irritant-induced. Frequently, vocal cord dysfunction occurs in conjunction with the workplace. Next, I'm going to explain the pathophysiology of upper airway obstruction. I'll emphasize the differences between upper and peripheral or lower airway obstruction. Central to this explanation is the differences in changes of airway diameters that accompany inspiration and expiration due to the pressure changes. Intrathoracic airways are expanded by inspiration and compressed by expiration. This compression is known as dynamic compression. On the other hand, extrathoracic airways are collapsed by inspiration and expanded by expiration. This slide attempts to show the relationships between airway location inside and outside the thorax and the pressure changes that occur with inspiration and expiration. On the left, inspiration pulls the intrathoracic airways open but tends to collapse the upper airways. On the right, expiration collapses the intrathoracic airways and tends to open the extrathoracic airways. Well, so what about the pathophysiology? What it means that in upper airway obstruction, that inspiration is more vulnerable to obstruction than is expiration. It also means that turbulent flow, which predominates in the large airways, provides an additional source of resistance and also provides the rationale for using Hellox in upper airway obstruction because it reduces the resistance to flow where there is turbulent airflow. Next, we're going to look at the manifestations, the signs, symptoms, and findings in upper airway obstruction. For some of these conditions, such as vocal cord dysfunction, there may be chronic symptoms in the history. It may be exercise-induced, and it may also be exacerbated by the work environment. Dyspnea, cough, and hoarseness are also common findings. The medical history may include previous treatment for asthma, where the original condition has been misdiagnosed as asthma, such as vocal cord dysfunction. There also may be a history involving sleep apnea, possibly a history of intubation or tracheostomy, allergies, psychiatric illness, and also upper respiratory infections. There also may be a history of occupational exposure to either allergens or other forms of inhalants. Physical findings in upper airway obstruction may include mild to moderate dysphonia, that is hoarseness, possibly stridor, and maybe wheezing that is referred to the periphery from the neck. Always listen at the neck to see if the sound isn't originating from there. In severe obstruction, there may be inspiratory retractions. These may be supraclavicular as well as intercostal. The patient may be unable to swallow, producing dysphagia and drooling. Stridor may be a common sign. Abdominal paradox is an ominous sign because it indicates that there is diaphragmatic fatigue. Another ominous sign is cyanosis. The best way to discriminate between upper and peripheral obstruction is done with a flow volume curve, which will show decreased flows on inspiration for upper airway obstruction as shown on this slide. Given the availability of portable spirometers, there is no reason why we should not obtain flow volume curves for our ER patients to ensure that our treatment is appropriate. We may be treating our patients with beta-adrenergic drugs when what they need is Heliox. My personal bias is for all ERs to also have Heliox available for upper airway emergencies. Other diagnostic procedures may also be needed. Imaging like radiographs and CTs can be helpful in some conditions. However, procedures like laryngoscopy and bronchoscopy, where we actually go down and visualize the structures, may be required. Now we're going to proceed to discussing management of upper airway obstruction. Patients who are in impending ventilatory failure as determined by physical findings and by monitors like desaturation on the pulse oximeter require immediate relief. For some patients, Heliox will work by reducing airway resistance because it decreases gas density. It can provide immediate relief, however, it is only a temporary measure. Other patients in impending ventilatory failure will require emergency airways, such as endotracheal intubation, cricothyrotomy, or even tracheotomy. Foreign body aspiration is treated by removal of whatever has been aspirated as assisted by either laryngoscopy or bronchoscopy, depending on the location of the aspirate. Patients with suspected epiglottitis should be approached with extreme caution. They need antibiotics to fight the microorganism. In the meantime, it's very likely that their upper airways will close down completely. Therefore, they need intubation, they need sedation, possibly paralysis, and mechanical ventilation while we wait for the antibiotics to work. When this protocol is followed, there is always a happy ending. It scares the heck out of the patients because their kid is intubated, but this is just to keep an airway until the antibiotics can work. We've historically treated croup with inhaled racemic epinephrine. However, inhaled steroids, specifically budesonide or pulmicort, have shown greater effects in preventing patients from being admitted to the hospital with croup. An article that was published within the last couple years, they did a study on mist therapy for croup and found that it had no beneficial effects and it could be harmful. Therefore, mist therapy should not be used. Chronic tonsillitis is, of course, managed with antibiotics and eventually a tonsillectomy. The key to management of anaphylaxis is epinephrine, intravenous and subcutaneous, but also diphenhydramine or Benadryl is administered. Steroids are administered to help the body cope with the stress. And finally, we may need to give the patient albuterol because of residual bronchospasm that accompanies the anaphylaxis. We have all managed post-extubation tracheitis a time or two. This is edema caused by irritation from the endotracheal tube. Historically, the treatment of choice has been racemic epinephrine because of an article that was published around 1970 that supported its use. Racemic epinephrine is a weak alpha, beta-1, and beta-2 stimulator, which has a duration of action of only 90 minutes. Personally, I think that we should test other medications for this. For instance, long-acting alpha adrenergic for this condition. This is a good idea for clinical research if anyone is interested. Besides adrenergic drugs, inhaled and/or systemic steroids are effective in reversing the inflammation that produces the edema, and Heliox can reduce the work of breathing until the edema is resolved. For inhalation injury, we also might select racemic epinephrine, again because of history. However, steroids may be helpful here as well. Beta adrenergics for the accompanying bronchospasm, and again, Heliox might help reduce the work of breathing. There is an excellent article on the use of Heliox in critical care that you can go and take a look at. There's a link below there. Now we'll talk about management of vocal cord dysfunction. The first problem is in diagnosing it so that we know that we're not treating asthma. Indeed, we're treating upper airway obstruction. For severe exacerbations, helium oxygen therapy may save the patient's life or may prevent a tracheotomy. For some patients, anticholinergic aerosols, that is Atrovent, may be effective for exercise-induced vocal cord dysfunction. Adrenergic drugs have no place in treatment of VCD. For other patients, CPAP may be effective. Additional strategies to manage patients with vocal cord dysfunction may be involve removing them from whatever exposures if there's an environmental cause, that is, quit their jobs. Speech therapy can be helpful by educating the patient about their condition, but speech therapists can also teach the patients various breathing exercises, including panting. For some patients, psychotherapy may be necessary, and also in conjunction with the psychotherapy, medications such as sedatives, anxiolytics, other recreational drugs. Obstructions that are due to neoplasms, congenital anomalies, trauma, or hematoma can be managed with Heliox until such time as surgery can relieve the obstruction. For some of these patients, cricothyrotomy may be indicated. For many of them, surgical resection will also be necessary. Regardless, Heliox can reduce the work of breathing temporarily until the surgery is done. Keeping in mind we cannot do this for a prolonged period of time, Heliox is also very expensive. Finally, for our patients with tracheal stenosis, there is hope. Formerly, patients with stenosis would undergo tracheal reconstruction, which sometimes backfired by causing scar tissue which worsened the stenosis. I had a patient years ago whose tracheal diameter was 5 millimeters at the scarred area after this procedure. Now, stenosis can be managed by placement of stents. Click on the link below to see the stents as well as their placement. That concluded the new information for this presentation. Let's summarize and review for a bit. We talked about the etiologies of upper airway obstruction. These are congenital infections and various forms of edema. And we also talked about other acquired causes of upper airway obstruction, such as acquired tracheal stenosis. Then we talked about the pathophysiology of upper airway obstruction, emphasizing that there is compromised inspiratory flow And since this is in the large airways, there is turbulent flow, which means that Heliox will be effective in managing airway obstruction of the large airways. We talked about the manifestations of upper airway obstruction, which include evidence of increased work of breathing, stridor, and wheezing. We also looked at the diagnosis, which is primarily decreased inspiratory flow rates, as we can see on a flow volume curve. We can also sometimes visualize an aspirate through bronchoscopy or laryngoscopy, and sometimes medical imaging is also helpful. The management of upper airway obstruction, if it is an emergent case, there will require surgical intervention. Again, sometimes we can give Heliox until the cause is resolved. Antibiotics are necessary for the infections. Steroids are useful to reduce the inflammation. Surgical resection will be necessary for some of these, especially tumors. And for stenosis, tracheal stenosis, stents can be placed.